Hi, my name is Andrea Aguilera. My topic about is atenolol versus losartan in children and young adults with Marfan syndrome. Definition: Marfan syndrome is an autosomal dominant genetic disorder with a prevalence of 1 every 5,010 newborns, so it is classified as an uncommon disease. It affects multiple organs and systems. Its prognosis is marked by the cardiovascular involvement. Multidisciplinary follow-up these patients allow the time-lapse diagnosis of complications and improve their quality of life. Marfan syndrome happens because of an abnormality in one copy of a gene that causes problems with the body production of the protein fibrillin. This protein is an important part of connective tissue. Weakened connective tissue can lead to problems in many parts of the body, especially the heart, eyes, and bones. Application in medicine. It is antagonist to receptor antagonist. It works by blocking specifically and highly selectively the binding of angiotensin II to type 1 angiotensin receptors present in the arterial wall and other tissues. As a consequence of this block, there is an inhibitor of the vasopressor and aldosterone releasing effects. By not blocking the synthesis of angiotensin II, it acts on type 2 angiotensin receptors, producing vasodilatation and other beneficial effects such as angiogenesis, natriuresis, kaliuresis, and increased urine production. Unlike angiotensin converting enzyme inhibitors, they do not interfere with the breakdown of bradykinin, and since its accumulation does not occur, it does not cause the adverse effects derived from it, such as gout and angioedema. Pros and cons. Pros: losartan therapy in mice with Marfan syndrome, preventing elastic fiber, ground fragmentation, and therefore preserve aortic wall architecture. Losartan also decreases the rate of aortic root dilatation into a small series of children with Marfan syndrome. Cons: among children and young adults with Marfan syndrome who were randomly assigned to losartan or atenolol, we found no significant difference in the rate of aortic root dilatation between the two treatment groups over a 3 year period. Issue applying in Ecuador. In the country, 106 cases are officially known, but there could be up to 400. Due to inbreeding and consanguinity, there are some rare entities with a high percentage of affectation. Conclusion: Marfan syndrome is an entity that is transmitted in an autosomal dominant manner, clinically characterized by a triad that includes skeletal, ocular, and cardiovascular manifestations. Within of the skeletal ones are aerodactylity, joint laxity, protrusion of the septum, depression of the septum, decrease of the radius between the upper segment and the lower segment displaces vertebrae, specifically in the spinal lumbar, flat foot, acetabulum protrusion. Thank you.
So the NIH Marfan trial is going to be the biggest trial for Marfan syndrome ever done. It's a trial that's sponsored by the NIH, so it's funded by the federal government, and it's being run by the Pediatric Heart Network, which is a research network that was started in 2001 to try to do research on kids with heart disease with the long-term goal of improving outcome. The Marfan trial was started in 2007. And in the course of the trial, we've recruited 608 young children and young adults. Half of the subjects are getting atenolol, and the other half are getting losartan. We do know that children and young adults with Marfan syndrome are tolerating both of these medicines very well. In addition to trying to figure out which medicine is better at slowing your aortic enlargement, we're going to learn a lot about side effects of the medicines. We're going to learn whether these medicines are helping other parts of your heart, your mitral valve, your left ventricle. We're looking at the effect of these medications on growth, on your skeleton, whether these medicines affect your pectus or your scoliosis. So we're going to learn a great deal, not only about the effect of atenolol and losartan on your heart, but also on the rest of your body. We've all invested a lot of time, money, and talent trying to get this trial done. And sometimes I'm afraid that we may end up at the end of the trial with results that we didn't expect, or results that don't move the field. But because we're looking at a lot of different things, I think that we're going to learn a lot, even if the study shows no difference between losartan and atenolol. So that keeps me going.
Marfan syndrome. It is an autosomal dominant multisystem genetic disorder characterized by abnormal manifestations in the skeletal, cardiovascular, and ocular systems. The typical facial features observed in Marfan syndrome include an elongated face, flat cheekbones, a posteriorly positioned jaw, deep-set eyes, and down-slanting palpable fissures. Abraham Lincoln had several of these features, but did he have Marfan syndrome? Well, who knows? Increased linear growth of the long bones is a common finding and generally results in tall stature with long limbs. The torso length to leg length ratio is often reduced, while the arm span to height ratio may be increased. Thoracolumbar scoliosis, as seen in this image, is also commonly present. Increased joint laxity and arachnodactyly are common, and when both present, the combination can result in a couple of signs. The wrist sign is positive if the distal phalanges of the thumb and fifth finger overlap when the wrist is grabbed with the opposite hand, and the positive thumb sign is present when the entire distal phalanx of the inducted thumb is visible beyond the ulnar border of the hand. Some other common skeletal manifestations include pectus excavatum, pectus carinatum, hindfoot valgus, and flat feet. A variety of ocular manifestations can occur, such as subluxation of the corneal lens, myopia, cataracts, and glaucoma. Ectopia lentis, in which the lens is typically displaced upwards and temporally, is a cardinal feature of Marfan syndrome. Aortic dilation is a potentially life-threatening complication that can occur. In these images, we can see that the aortic root is abnormally wide. Aortic dissection is another serious complication. In this echocardiography, we can see a double lumen. Blood flow during ventricular systole indicates that the upper lumen is the true lumen. Two other cardiac manifestations that commonly occur in patients with Marfan syndrome are mitral valve prolapse and the bicuspid aortic valve. As well, many other non-cardiac abnormalities may be present, such as hernia and skin striae. Now, although it is an autosomal dominant condition, the phenotypic expression is highly variable. Affected parents may not even be aware that they have it and may negate a family history of the disease. De novo gene mutations can also occur, in which case no other family member will be affected. The diagnosis can be made if two or more of the following are present: family history of Marfan syndrome, ectopia lentis, aortic dilation or dissection, or a causal mutation in the FBN1 gene. It is important to note that a minority of patients with Marfan syndrome do not have a defined FBN1 gene mutation. If the patient only has the aortic criterion or a positive family history, then a systemic score of 7 or more in the revised Ghent criteria is required. Screening with echocardiography is recommended at 6 to 12-month intervals. When managing patients with Marfan syndrome, it is important to consider therapy with beta blockers and to advise them to avoid caffeine, stimulants, weightlifting, and high-intensity contact sports. The addition of an angiotensin receptor blocker